Sunil ji. Please pause the live.
We are
Yeah, we've already gone live, madam. So, Sunil ji, are we live? Or we
yes,
have
sir, we are
to
right.
pause? Okay, then we'll perhaps begin then. So, a very warm good evening, rather in this cold winter evening. And I welcome all of you all to this fantastic new session of case presentations. We have two very interesting cases today, rarely touched upon, but when these cases do come in as in your exam, in the examinations, it can be baffling. So it's a good opportunity for everybody to know and understand these two cases. So we'll be having a case by Dr. Snehal Goe, who's a junior resident in the Government Medical College in Chhatrapati Sambhaji Nagar, and ably mentored by Dr. Mahesh Sonpetkar, who's an assistant professor in Government Medical College, Chhatrapati Sambhaji Nagar. Now she'll be presenting a case on complete third nerve palsy. And the second case is going to be by Dr. Pooja Rathi, who's a junior resident in Sri Ganpati Nethralaya, Jalna, ably mentored by Dr. Vishali Kare, who's a junior consultant in Sri Ganpati Nethralaya in Jalna, of course. And we'll be having two examiners. One is, of course, our national examiner, additional professor at Tarpi Center names, our own from Maharashtra, Dr. Swati Pulze. And we'll have Dr. Prachi Agashe, who's a renowned consultant pediatric ophthalmology in Mumbai. She practices at, of course, KB Bachuwali Hospital in Mumbai, who's going to be a state examiner. Now, the session is going to be moderated by, of course, our very own member of the scientific committee and HOD GMC Chhatrapati Sambhajinagar, Dr. Archana Vare. And before I hand it over to Dr. Archana Vare, I would also like to welcome Dr. Anaga Herur, who's the president of MOS, to say a word of motivation to both our students, and then we'll quickly go on to the cases. Dr. Archana Professor Vare will describe the format wherein we'll proceed after that. So, Dr. Herur.
Yeah, thank you so much, Dr. Piyush, and very warm welcome to everyone here. And MOS is always, tried to be on the forefront in getting the best speakers. Very innovative, good job, Piyush, for this. And all the best to both the presenters. And let's have a great session tonight. All the best.
Okay, thank you, Dr. Anaga.
Yeah.
So we have two case presentations. So till 8:30, the first case will be over, and 8:30 to 9, there will be second case. So the presenter will present in 8 to 10 minutes, and the examiners, the national and the state examiners, they'll ask them the questions. So we'll go to Dr. Snehal's case first. So I request Dr. Snehal to start sharing her screen.
Yes, ma'am. Thank you, ma'am.
Snehal?
Yes, ma'am. Shall I begin, ma'am?
Yeah, please.
Okay. Thank you, ma'am. A very good evening to all the faculty members present. I am Dr. Snehal Gore, Junior Resident, Department of Ophthalmology, GMC Chhatrapati Sambhaji Nagar. And today I'm here to present a case under the guidance of Dr. Archana Vare, ma'am, and Dr. Mahesh Sonpetkar, sir. 18 years old female resident of Chhatrapati Sambhaji Nagar.
Sir, I'm very sorry to interrupt you. There is a small notice which is coming there. Can you just remove
Just
it?
press on hide. Just press on hide.
Okay.
Yeah.
Yes. Okay. A 18 years old female resident of Chhatrapati Sambhaji Nagar came to ophthalmology OPD with chief complaints of double vision in both eyes since 15 days. and inability to open her right eye upper lid since 12 days. The patient was apparently all right 30 days ago when she was diagnosed with tuberculous meningitis with pulmonary tuberculosis. Patient started noticing double vision since 15 days when both eyes were open with no aggravating or relieving factors. Patient also complains of drooping of right eye upper lid since 12 days, which was acute in onset and progressed to the current state. Now, the patient had no history of trauma, no history of pain, redness, or swelling around the eye. There was no history of excessive thirst, frequent urination, increased hunger, no history of abnormal movements in any parts of the body or loss of balance. There was no history of any ocular surgery. There was no history of diurnal variations in the drooping of eyelid. There was no history of any drug intake. And there was no history of any similar episode in the past. The patient was diagnosed with tuberculous meningitis with pulmonary tuberculosis 30 days ago and was started on anti-cox treatment. Now, we had done the laboratory investigations of the patients, which were within normal limits. The erythrocyte sedimentation rate was on the raised side, which was 75 millimeters per hour. The C-reactive protein of the patient was also raised, which was 1.8 milligrams per dl. The sputum acid-fast bacilli test was positive. The CSF CBNAT was positive for Mycobacterium tuberculosis, and the serostatus of the patient was negative. This is the CBNAT report of the patient where it shows Mycobacterium tuberculosis detected. This is the CSF analysis of my patient where we can see there is increased protein counts and decreased glucose levels, and the cytology shows lymphocytosis. The adenosine deaminase levels of the patient were raised. The patient is currently on antitubercular medications, that is the fixed dose combination of isoniazid, rifampicin, pyrazinamide, and ethambutol. And she's also given tablet vitamin B6, pyridoxine, 100 milligrams OD, with tablet dexamethasone 4 mg in tapering doses over a week. She is also given paracetamol 500 milligrams SOS. Now the appetite of the patient was reduced. Her sleep, bowel, and bladder habits were normal. My patient is thin built with general conditions fair and she's well oriented to time, place, and person. Her pulse rate was 73 beats per minute. Her blood pressure was 114 by 76 millimeters per mercury. There was slight pallor present with no evidence of icterus, cyanosis, clubbing, or any lymphadenopathy. The systemic examination showed no abnormality. Now, on ophthalmic examination, there was no abnormal head posture with facial asymmetry. On eye alignment, the right eye was directed downwards and outwards. This is the profile picture of my patient. On retracting the right eye upper lid, we can see that the right eye is deviated downwards and outwards. These are the 9 gaze photographs of my patient where we can see in the primary gaze, the right eye is directed downwards and outwards. There is limitation of movements in the dextro elevation, dextro depression, levo elevation, levoversion, levo depression, elevation and depression. Their moment is only seen in dextroversion. Now, I would like to describe the right eye findings first. The unaided vision of right eye was 612 parts, which improved with pinhole to 6.6. On retinoscopy, the horizontal and the vertical axis was neutralized with plus zero point 0.5 diopter sphere, which was done on dilated pupil with 0.5% tropicamide at 2/3 meter distance. The best corrected visual acuity of my patient was 6 by 6 with -1 dioptric sphere, and the near vision of the patient was N10. Color vision of the patient in right eye was normal, which was taken on Nishiara chart. The left eye findings were the unaided vision was 6.9 parts, which improved with pinhole to 6.6, and the retinoscopic horizontal and vertical axis was neutralized with +1 dioptric sphere. The best corrected visual acuity of my patient in left eye was 6 by 6 with -0.5 dioptric sphere, and the near vision was N6. The color vision of my patient was normal on Nishiara chart. The right eyebrows were normal, with eyelids showing complete ptosis with poor Bell's phenomenon and eyelashes being normal. The left eye eyelids, eyelashes, and eyebrows were normal. Now, the right eye interpalpebral vertical diameter was 0 millimeters with horizontal 28 millimeters. The conjunctiva showed no congestion and cornea was normal size, shape, surface, regular and clear, and the corneal sensations were present in all quadrants. The anterior chamber was normal depth with Van Herrick grade 4. The left eye vertical interpalpebral fissure was 10 millimeters and horizontal was 28 millimeters, with conjunctiva showing no congestion, and the cornea was clear, normal size and shape, surface regular and clear, with sensations present in all quadrants. The anterior chamber was normal depth with Van Herrick grade 4. Now the right eye iris showed color pattern normal with pupil being circular, central, mid dilated up to 7 to 8 millimeters in size and not reacting to light. The pupillary aperture was clear and the intraocular pressure was 16 millimeters of mercury on Goldman applanation tonometry taken at 1 p.m. The sac showed no rigor on pressure. The left eye color pattern of iris was normal, and the pupil was circular, central, and reacting to light. The pupillary aperture was clear, and the intraocular pressure was 18 millimeters on Goldman applanation tonometry taken at 1 p.m., and the sac showed no regurgitant pressure. These are the slit photographs of right eye and left eye, where we can see anisocoria in the right eye. The right eye pupil is mid dilated, 7 to 8 millimeters in size, and not reacting to light. Now, on fundus examination, on distant direct ophthalmoscopy, we can see red glow, and on direct and indirect ophthalmoscopy, the media were clear, disc was normal size, shape, and color, where the cup to disc ratio was 0.3, and the margins of the disc were distinct. The arteriovenous ratio was 2:3, and the foveal reflex was seen in both the eyes. Now, the special test we've done in this case were other cranial nerve examinations, which were normal, force duction test, which was negative, ice pack test was negative, fatigue and Kogan's test were negative. Now, coming to the diplopia charting of the patient, here we can see that the right eye image is formed on the left side and the left eye image is formed on the right side, denoting it was a crossed diplopia. Then we can see the only single image is formed in dextroversion, which eliminates the involvement of right eye lateral rectus and left eye medial rectus. Also, the right eye image is more towards the periphery, eliminating the left eye muscles involvement, and we can see that the right eye image is tilted towards the right, that is the right eye is intorted, that which indicates that the superior oblique is not involved. So we come to a conclusion that there is involvement of the right eye superior rectus, inferior rectus, medial rectus, and the right eye inferior oblique. Now, this is the hair starting of my patient, where we can see that the right eye image is contracted. The central dot in the right eye is.
Snail, can you use a laser pointer
Yes, ma'am.
if possible?
Yes, ma'am. So we can see in the right eye that the image is contracted. The central dot is deviated downwards and outwards, and there we can see under action of the superior, medial, and the inferior rectus. Whereas we can see there is overaction of muscles in the left eye, that is the superior rectus, inferior rectus, and the medial rectus, and there is underaction of the muscles in the right eye. The MRI brain was done of the patient and which showed basal leptomeningeal enhancement seen around the interpeduncular and suprasellar cisterns, suggestive of basal meningitis, tubercular etiology, and there was small focal area of restricted diffusion in the right midbrain, indicating ischemic involvement secondary to vasculitis. There was no evidence of any mass, hemorrhage, or abscess. So my provisional diagnosis was right eye complete third nerve palsy with pupil involvement secondary to tubercular meningitis in a known case of pulmonary tuberculosis with both eye simple myopia. Thank you.
Very good presentation, Snail. Please stop sharing your screen.
Yes, ma'am.
And I request Dr. Prachi ma'am to ask questions to Dr. Snehal.
Yeah. So very well presented, Snail. Very comprehensive presentation.
Thank you,
I'm
ma'am.
going to ask you some basic questions actually. So why do you think that this patient did not have a head posture?
Ma'am, as there was ptosis, so the patient did not acquire any specific head posture. A complete ptosis was seen, so there was no any head posture seen in the patient.
Because of the ptosis, the patient did not experience any head posture change.
I think she's lost the connection. It's traveling. Prachi ma'am, are you there? Dr. Vrushali ma'am, are you there?
Yes, ma'am, I'm there.
Yeah, you can also ask questions, ma'am, no problem.
Okay.
Yeah, she's there now. So, Dr. Prachi, you were asking
Yeah,
something.
yeah. So, what are the components of a head posture? I mean, in case you have to describe a head posture, what are the components in which you can describe it?
uh, we can describe usually in the face turn, then
Very good,
the head elevation and chin elevation, head tilt or chin elevation.
very good, excellent. And how do you perform a force duction test? How did you perform a force duction test for this patient?
Ma'am, we anesthetize the patient topically, and then we ask the patient to look into the direction of the muscle which is to be tested. That is the action of the muscle which is to be tested. And we, with the help of limbs forceps, we uh, hold the limbus at the 180-degree opposite side. So that is, if you are testing for the medial rectus, we ask the patient to adduct the eye, and we hold at the limbus 180-degree opposite side, and then we try to pull the eye towards the direction of the muscle. And if we can pull, then it suggests of paralytic etiology, or if there is a restriction, it suggests that it is a restrictive pathology.
Okay, good. And how can you check for the action of superior oblique in this patient?
uh, for superior oblique, we ask the patient to look uh, downwards, and there is downwards in the abducted position, and then we can see the intorsion of the eye. We can mark the nasal vessels and see the intorsion.
Good. Um, and how often would you like to follow up this patient?
As it is pupillary involvement, we can uh, have to follow up the patient 2 weekly, or we can go, as it is a young patient, we have to go for imaging immediately to get the cause, as there are chances of artery aneurysm seen in young patients. So we can go for neuroimaging immediately, and we can
Like you have
follow up the
already, yeah, okay, good. And can you improve the near vision for this patient? The near vision was N10, right?
Yes,
So
ma'am.
how can you improve the near vision for this patient?
Ma'am, as usually the nerve undergoes spontaneous recovery, and the patient might recover the near vision, or we can,
Why is the near vision less for this patient?
ma'am, the accommodation is hampered as the third nerve supplies the ciliary muscles also. So the accommodation is hampered. So if the nerve recovers, the near vision also will recover.
Good.
I think Swati
I
ma'am
think
has
that's all from us.
yeah. Swati ma'am,
Hello, hi. Hi.
hello ma'am. Ma'am, would you like to ask a questions? Third no palsy.
Yeah, Snehal, that was really a good case and very well presented, I must say. As Dr. Prachi asked you that, when you're doing force duction test, what are the key things that you need to keep in mind?
Oh, we go for topical anesthesia and we have to ask the patient to look in the direction of the muscle we are testing, the direction of the so that the agonist and the antagonist actions are at the equilibrium.
Okay, so for example, in your case, you want to test for the tightness of.
Lateral rectus,
Correct. So you will ask patient to look.
in the adducted position.
So you want to look, ask patient to look in the adducted position. Why? Because.
The medial rectus is palsied here.
Okay.
So we have
So,
to check for any restriction of the muscle in the lateral position.
so what happens when you ask patient to look medially? What happens to lateral rectus?
The lateral rectus is overacting here. So there is
No,
overaction,
overacting in general. Why? Because medial rectus is paralyzed. Correct.
paralyzed.
I'm
Yes, ma'am.
saying when you ask patient to look medially, what happens to lateral rectus? What do you expect?
The lateral rectus is e- uh,
So even in normal conditions, when there is no pathology, if you ask patient to say look on medial side, right? Or maybe if you ask patient to look on the right side, your right lateral rectus will get innervation. Am I right?
inhibitory innervations.
Correct. So the idea is to relax the
Relax the
antagonist muscle, right? So that
yes,
you
ma'am.
don't get a falsely positive
Positive.
post-duction test there.
Yes, ma'am.
Okay, and what else will you keep in mind when you are doing FDT? Apart from relaxing the antagonist muscle, what else?
We should not retropulse the globe as it might give false positive tests.
Falsely negative. If you
Falsely
retropulse, you
negative.
are relaxed. So for recti, you need to elevate
Elevate the
the
globe.
globe. For
Yes, ma'am.
oblique, you need to depress the globe,
Depress the globe.
right? Otherwise, you may get falsely negative test. Okay. Then, as you very rightly said, that in a case of third nerve palsy, right, you can check for intorsion. It's very important to check for intorsion, right?
Yes,
Why is it important to check for intorsion? So you'll ask patient to look from up to down, correct? From up gaze
yes,
to
ma'am.
down gaze, and check for the intorsion of a limbal vessel.
Yes, ma'am.
Correct. That's the only way you can check for fourth nerve palsy. Now, why do you want to know that?
Ma'am, to locate the lesion, if there is involvement of the fourth nerve and the third nerve, then it might be a cavernous sinus pathology.
Correct. So more
Yes.
than cavernous might be a superior orbital fissure syndrome.
Fisher
So
syndrome
that's very important to understand that the fourth nerve is involved or not, or more than one cranial nerve is
is
involved or not.
in. Yes, ma'am.
Correct. In your case, you said there was basal meningitis, isn't it?
Yes, ma'am.
Correct. So in such cases, apart from third nerve palsy, it's not very common to have third nerve palsies in such cases. What is much more common?
Oh, the sixth nerve is involved in the basal
Why?
region.
Why so? What will meningitis cause?
Meningitis might lead to raised ICT, raised intracranial pressure, and there is inflammation in the basal region. So that might lead to sixth nerve palsy there.
No, inflammation is not the cause for sixth nerve palsy, right? What is pseudolocalizing sign? You said no, sixth nerve palsy can happen. So, what is a pseudolocalizing sign in cases of sixth nerve palsy?
Pseudolocalizing sign. Ma'am, it is seen in tentorial herniations where there is ipsilateral, contralateral third nerve palsy uh, due to raised ICT and uncle herniation.
Uncle herniation will generally lead to third nerve palsy. You're absolutely right. But in your case, that was not seen. There
No,
was no herniation there,
there.
right? And there was no sixth nerve palsy. So I'm little surprised what was the cause of third nerve palsy in this particular case. Okay, that's one question. Second question is, when you have meningitis, you, as you said, there is raised ICT.
Yes, ma'am.
Okay, so what happens when there is raised ICT? What are the features, ophthalmic features of raised ICT?
Ma'am, there might be papilledema seen on fundus examination.
So was it
And
there
there,
in your case?
no, ma'am, the fundus examination was absolutely normal. Also, the patient didn't complain of any headache or nausea, vomiting.
Okay, so what is pseudo-localizing sign in such cases? For sixth nerve, it is described for sixth nerve, not for third nerve. It may be applied to third nerve as an extension, but it is classically described for sixth nerve. What happens to sixth nerve in cases of raised ICT?
Compression of the sixth nerve is seen.
Against?
Uh, Against. I'm sorry, ma'am, I couldn't recollect.
Okay, so it's against the petrous ligament that it gets compressed, and that's the sign. That's what is known as pseudo-localizing sign, because you feel that the sixth nerve somewhere, the sixth nerve is getting compressed, but it's ideally because of raised ICT.
Okay.
Okay, so these are the things you should keep in mind. And what else should you keep in mind whenever you are dealing with a patient of TB?
The signs of ocular TB, we can go for fundus examinations and any other involvement of.
Okay, correct. Yours
Yes.
is probably disseminated TB. Why? Because there is TB, PTB, I mean pulmonary TB, as well as TB meningitis. So maybe it's a disseminated case. I'm really not sure, but that is a possibility. So, what precautions will you keep in mind? I mean, how will you follow up? What are the things that you are going to look in follow up for this patient?
We can go for regular fundus checkups of this patient if she's developing any signs of tubercular meningitis
It's
or
already there.
ocular signs of TB.
Okay, maybe. What else? What is much more important?
We have to follow up the patient for the improvement in the third nerve.
That you will obviously. What else?
The drugs which are used in tubercular meningitis may have ocular effects, so that we need to follow up for the patient.
Which drug?
Ethambutol.
Correct. So you must be careful about ethambutol in your follow up to check for what will you check for in cases of ethambutol follow up?
Macula of the patient, the color, like we need to test the color vision of the patient during follow-ups, and the macula with fundus examinations.
What do you expect to be seen in macula?
uh, Bullseye maculopathy due to ethambutol.
Is it described in ethambutol? Bullseye maculopathy is seen in which cases? Which toxicity?
It is also seen in hydroxychloroquine toxicity.
Right. So maculopathy is feature of HCQ toxicity and not ethambutol toxicity. What do you expect to see otherwise?
Any toxicity to the optic nerve or
So most of the time you may see in early stages the fundus may be absolutely normal. And that is the reason why fundus examination itself may not be a good way of looking for toxicity. You probably will have to check for color vision,
And
contrast vision, and
okay.
fields. And more important, you may have subclinical involvement of optic nerve due to ethambutol, which you can pick up on VER. VER may be a little far-fetched, but color vision and vision is the basic
Vision
thing.
basic.
And you have to tell patient about it, right? You can't miss it.
Yes,
Okay.
ma'am.
That's it. That's it from my side. Thank you.
Thank you, ma'am.
One more important thing when you present a case of third nerve palsy is the course of third nerve palsy and the lesions which occur at the various levels. So from the signs, you can find where the lesion is clinically. So that is also a very important, and you have to know the course, the nuclear complex, and how the third nerve, how is the course of the third nerve, and what is the difference between the diabetic and the non-diabetic third nerve palsy. So all these cases are very relevant for the PG exam. So
Yes.
Dr. Snehal, very well presented, and congratulations to Dr. Mahesh for mentoring her so well. And now we move on to the next case, and the next case is by Dr. Pooja, and she's mentored by Dr. Brushali. So I request Dr. Pooja to start sharing her screen and start presenting her case.
Good evening, all. So, I'll be presenting under my mentor, Dr. Vishali Kare ma'am.
Sorry to disturb you. Can you make it a full screen? Slideshow. Yeah. 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 Good. Start presenting, Pooja.
Yes, ma'am. Actually, huh. So, a 60 years old male resident of Akola, Maharashtra, was got to the squint clinic by his children with chief complaints of double vision since a day and having right face turn. So, the patient was apparently all right a day back and he suddenly developed double vision, which was painless, sudden in onset, painless, increasing in right gaze, and the patient having decreased separation of images with right face turn. Since then, both these complaints were non progressive. They then consulted a local physician and was referred to our center. The negative history that there was no history of fever or seizures or recent systemic illness, no history suggestive of any focal neurological deficit or hearing loss, no history of trauma, no history of any injections taken into the eye, no history of any ocular surgery, no history of eyes protruding out with any systemic symptoms, no history of diurnal variation in symptoms or any droopiness of eyelids, no history of similar complaints in the past, and no history of use of any spectacles. There was no history of squint in the family, and the patient consumes a mixed diet with sound sleep and appetite, normal bowel and bladder movements, and having no addictions at all. The patient was diagnosed with diabetes and hypertension 6 months ago, was on homeopathic medicine with poor compliance to the same. The general examination, the patient was conscious, cooperative, oriented to time, place, and person. The build, temperature, and pulse was within normal limit, but the blood pressure was slightly raised. It was 170 by 100 mm of Hg. The respiratory rate was 18. There was no pallor, icterus cyanosis, clubbing, or lymphadenopathy. The CVS, CNS, RS, and Porapto systems were perfectly normal. The cranial nerve examination was done, where the olfactory nerve was checked with the coffee beans with in front of each nostril, which was normal. The optic nerve was tested by visual acuity. The color vision was tested by Ishihara, and the direct consensual right reflexes as well as the accommodation reflex was checked. The confrontation test was done for field of vision, which was normal. The third, fourth, and sixth nerves were tested for the extraocular muscle movements, and what we found that the right eye, the abduction was affected. The trigeminal nerve was tested by using the cotton wisp over the ophthalmic, maxillary, and mandibular divisions were tested. The ophthalmic division was tested by the corneal reflex. The facial nerve was tested by asking the patient to elevate the eyebrows, to close the orbicularis oculi muscle, to blow his cheeks. The auditory nerve was checked by the tuning fork of 512 Hz, by the Renes and the Weber's test, which was normal. The glossopharyngeal nerve and the vagus nerve, the motor component was checked by asking but as the patient was not having any problem related to dysphagia or speaking. And also the glossopharyngeal nerve, the sensory component was tested by the sense of taste. The vagus nerve was again checked by asking the patient to say ah, and the symmetricity of the uvula was seen. The spinal accessory nerve was checked by asking the patient to shrug his shoulders, where the trapezius muscle was checked, and the sternocleidomastoid was checked by asking the patient to turn his head against the forced resistance. The hypoglossal nerve was checked by seeing the symmetricity of the tongue. So this is our patient. We can see there is a right face turn as the patient was reading. Okay. So there was the abnormal head posture, which was 10 degrees, which we measured by the goniometer. The facial symmetry was present and the surrounding ocular adnexa was within normal limits. The visual acuity without glasses was 6 by 18, and with correction it was 6 by 6. With near add of 2.5, the near vision was also N6. The lids were normal in shape with no inflammation or swelling. The conjunctiva was normal. The cornea was normal in shape, shiny, transparent, and having the corneal sensations normal. The anterior chamber was normal in depth. The iris was normal in color pattern. The pupil was central, circular, and reactive to light. The lens changes were NS1. The nasolacrimal passage was patent, and the intraocular pressure in both the eyes was 14. The sensory evaluation was done by Word's 4-dot test, where uncrossed diplopia for distance in forced primary position was seen. So this is our patient. He is having a slight ET esotropia in the right eye. We can see that in the dextro version, the left eye is having normal movement, but the right eye, the abduction is restricted, which is around -3. The levo version is perfectly normal. The elevation and the depression are also normal. We can see that the levo elevation and the levo depression are also normal, but the dextro depression and in dextro depression and dextro elevation, we can see the proportional limitation of movement because there is abduction limitation. The motor evaluation was done where the face turn was 10 degrees to the right side as measured by the goniometer. The forced primary Hirschberg was right esotropia. The cover test showed alternate esotropia. The extraocular movements showed right eye abduction 3 minus and rest of the extraocular movements were within normal limit. The alternate prism cover test, the primary deviation was measured where the prism was on the right eye and 18 PD right esotropia for distance was seen and 16 PD for the near was seen. The secondary deviation was measured with 25 PD right esotropia and 20 PD for near. So deviation in the right case was 30 PD right esotropia. The diplopia charting was done where the patient was seated in a dark room at 1 meter distance. The streak of light was placed onto the screen from behind of the patient. And what we saw that in the left case, there was no separation of images. In the primary case, there was minimal separation of the images, whereas the separation of the images increased on the right case. What we can see that for right eye, we have the red goggles. For left eye, we have the green. So it was a uncrossed diplopia, which was more in the right case. And hence, the pathologic muscle was the right lateral rectus muscle. The fundus, the CDR ratio was normal with the disc margins distinct. The AV ratio was normal and the fundus reflex was seen. So my probable diagnosis is right eye lateral rectus paresis, probably due to ischemic etiology. But rest of the etiologies like intracranial space occupying lesion, infectious and inflammatory etiologies had to be ruled out. And hence we went ahead with neuroimaging. What we saw is there was mild chronic small vessel ischemic changes. So further investigations were advised to the patient where the blood pressure was 170 by 100, the HbA1c was abnormal 8.4%, the BSL was 130, fasting and postprandial was 200, and the serum lipids were also deranged. So the patient was referred to physician for systemic control. From ophthalmic point of view, occlusion of the right eye was advised. The patient was advised not to drive and review in 2 weeks for follow-up to monitor the progression or regression. So thank you.
Thank you, Dr. Pooja, and please stop sharing the screen. Yeah, Dr. Pooja, it was a very nice presentation, and I request Dr. Swati ma'am first to ask questions to Dr. Pooja.
Hi, Pooja. It's very extensively worked up case, and you have presented it equally well.
Thank you, ma'am.
And the best thing about your presentation was, or your examination was, that you not only limited your examination to ocular features, but also examined the systemic neurological for systemic neurological signs as well. So no neuroophthalmic examination is complete unless you do a proper neurological examination also. So many a times we will miss the lesion if we don't do an entire if we don't look for involvement of other cranial nerves, like seventh nerve, eighth nerve particularly. 11th or 12th may not be so important from ophthalmic point of view, but 7th, 8th are very, very important, and 5th, of course. You said, interestingly, you first did MRI and then you did, your BP and sugar and other stuff. So if you have a case of isolated sixth nerve palsy in the patient of your profile who is 60-year-old male, what is your line of management?
Ma'am, actually, in a elderly population, actually, first coming to the case, we had advised both the investigations at the similar time. It's just that I presented it first the MRI and then the blood investigations and the reports.
Okay.
And yeah, so and mostly in this particular age group, 60 years, the elderly population, what we expect is most of the microvascular disease, like diabetes or hypertension, causing the isolated sixth nerve palsy. So, of course, first we have to go ahead with the blood investigations.
Right. So, in other words, what are the indications of imaging in a case of sixth nerve palsy?
Okay, so if the patient is a young patient, then we can suspect some intracranial ICSOL or any raised ICT. Then in that case, if there are involvement of the other cranial nerves like fifth nerve, sixth nerve, eighth nerve, we can suspect any of the syndromes like Gredenico, or any CP angle tumor can be suspected. So in that case also we need to go ahead with neuroimaging. If at all we see the sixth nerve involvement with papilledema, so that is another indication. And the last one more thing that I can think about is if the sixth nerve palsy is not recovering by 6 weeks, and rather it is just like it is progressing and not regressing, so that could be another reason where we could neuroimage the patient.
Right. So, in a case of sixth nerve palsy, if patient is young, correct, whether it is associated with other nerve involvement or not, you must do neuroimaging. Vis-a-vis in an old patient, as in your case, if you have systemic features of microvascular occlusion, you anyway have risk factors there. I'm sure you were aware of those risk factors even before proceeding for MRI. So it's an isolated sixth nerve palsy with presence of risk factors. Probably you may choose to defer. I'm not saying that you have to defer, but you may choose to defer imaging if and follow up patient. If there is recovery, then again no need of imaging. But yeah, of course, if there is no recovery in 4 weeks or 6 weeks time, then you do need to do neuroimaging, correct? So diagnosis probably in your case is not so difficult. It's probably in your face kind of a thing. How would you want to manage it?
Okay, so ma'am, considering the age of the patient, we would advise him that you do just monocular occlusion. If it would have been a younger child, like less than 8 years, then we would have given him the alternate eye occlusion because probably not so that the child doesn't develop amblyopia. But in this case, just monocular occlusion would suffice to the patient, and we would rather monitor him on a 2 weekly basis just to see that whether the palsy is regressing, so that we can just observe. And further, if he is concerned about diplopia, then Fresnel prisms can be given to the patient. And if he is not so concerned and just wants to be the same, so then he can just continue with the occlusion. And
The deviation in your case?
sorry, ma'am,
Amount of deviation.
18 PD.
Okay, so that's it.
So Fresnel prisms, we could just go
It's,
ahead with that.
it's already in recovering stage, isn't it?
Yes, ma'am.
So almost 99 will be higher percentage, maybe around 90% of ischemic cranial nerve pulmoneuropathies will recover on their own. So you probably don't need much of an intervention there, except yes, if patient is too much troublesome about diplopia, as you rightly said, you need to give monocular occlusion in such cases, or if the deviation is small, as in your case, you can give Fresnel prisms. Correct?
Yes, ma'am.
You
And
don't need surgery in such cases. If at all, how long would you like to wait for surgery?
6 to 12 months we would like to wait, and then depending on the FDT and the FGT, we would then decide whether we have to just go ahead with recession or resection, or we have to go ahead with the transposition surgeries.
Correct, correct. Can you do anything else in meantime apart from Fresnel prisms and patching, so that the FDT, so that the medial rectus does not go into contracture?
Botox could be tried. Botulinum toxin can be given. Now, suppose my right lateral rectus is paralyzed, so that means my right medial rectus would go into a contracture. So, Botox can be given here, like ideally 2.5 to 5 units could be given.
Great, great. Okay, that's all from my side.
Yeah,
Thank you, ma'am.
I request Dr. Prachi ma'am to ask questions to Dr. Pooja.
Yeah, Pooja, excellent presentation. Very
Thank you,
well
ma'am.
presented, and congratulations to the mentors also here. Okay, so some questions from my side. So, in the history, how would you really want to differentiate diplopia due to a monocular cause as against a binocular cause?
Uh,
Would you want to
we,
ask anything in the history?
mm, ma'am, by occluding one eye, if the patient is reporting that by
I can't
closure of
hear
the...
you.
Hello? Yes, ma'am.
Prachi ma'am, can you repeat the question, please?
Yeah, so my question is, am I audible?
Yeah,
Yes,
you
ma'am.
are audible.
Yes, ma'am.
Yeah. So, in the history, what would you want to ask the patient to differentiate a cause of monocular diplopia from binocular diplopia?
Ma'am, maybe he would just say that when I close one of my eyes, still I can see double, and then and in binocular, just with the two eyes, when he's seeing with the two eyes, at that time he's just reporting the double images.
Yeah, that's right. So, basically, closing one eye would relieve the double vision. That's the whole idea of even giving patching, right?
Yes,
Okay.
ma'am.
And would you like to check saccades for this patient?
Yes, ma'am. Just to differentiate between palsy and paresis, yes, we would like to check for the saccades.
How do you check for saccades in OPD?
Ideally, just the two targets are being held, and the patient is asked to alternately view on both these targets, and that's how we can check for the saccades.
And what would you see in a palsied eye?
In a
Any idea?
palsied eye, we would see that the velocity of the saccade as well as the amplitude of the saccade is decreasing.
So we generally see a floating saccade. So the eye doesn't really move and you see a floating movement in that direction. Very good.
Hmm.
I think with this, yeah, how would you do we want to have any differential diagnosis over here?
Yes, ma'am, definitely. For this case, we could even think of considering the age, we could think of the sagging eye syndrome. Then, even in high myopes, we can see that there's slight ET. Then, considering the age, DRS won't be a differential here, and even DRS or infantile ET won't be the differential here. But uh, apart from that, ma'am, even thyroid eye disease or myasthenia gravis could also lead to this.
Correct. And sometimes even some lesion into the muscle, in the opposite muscle. So I think FDT or a force duction test becomes very important over here to, kind of force duction and force generation test become important over here to clinch the diagnosis. So we discussed about force duction test. How do we go about doing a force generation test?
For first generation test, ma'am, we would first instill the topical anesthesia. Then after that, we would ask the patient to look into the direction of the paralyzed muscle, and we would hold the forceps at the muscle and feel a tug. So if at all you're feeling a tug, it means that it's not a paretic muscle. There is some strength into the muscle, and if we don't feel any tug, then that means it is a paralyzed or the palsied muscle. So where we
Good.
have to proceed
Yeah.
with the transposition surgeries.
All right. Yeah. Good. That's all from my side.
Thank you, ma'am.
Swati ma'am, would you like to ask any questions?
No, not really. I think she's really doing well. I hope she already knows what are the transposition surgeries. So let's not get into it. Right, right. Thank you.
Ma'am, I'd like to add a point here. Just one.
Yes, ma'am.
Yes, very,
I
ma'am.
was about to come to you.
No, no, ma'am. It was just regarding the neuroimaging. Ideally, would not be indicated in such a case. But many a times, what happens is we see the patient for the first time, and then we just completely lose them to follow up. There are so many patients who just don't follow us back. So that is the reason that just so that we don't miss. Ideally, though a patient is 65 with all the parameters, but still considering that they have so many multi-system disorder, sometimes just that because we don't lose them to or we may never see them again is the reason we advise neuroimaging.
You did not explain so much, Dr. Shali. I understand. I just wanted her to know.
Yeah, that's
Yes,
Know
yes,
fine.
that what is the importance of doing neuroimaging many a time, because particularly in rural areas patient may not be able to afford it, so you have to be clear in your mind why you want to undergo neuroimaging.
yes, yes,
That's
yes.
important.
Right, right.
That's nothing else.
Yes,
And
yes,
there is
ma'am.
nothing wrong in getting a
Yes,
neuroimaging done,
nothing wrong
honestly.
in
Yeah.
getting a
Yes,
So,
yes.
neuroimaging.
And sometimes patients are too over-informed. They will read and come, and
Yeah,
sometimes
yeah.
they make counter
You cannot
questions. So
justify
sometimes
that.
we
I
feel,
just wanted her
yes,
to
yes,
know.
ma'am. Yes, ma'am. No, ma'am. I just thought maybe
Yeah,
we tell the students as well, but
yeah,
just maybe that this is the medical legal part, and that is why we better be safe.
exactly, exactly.
absolutely. Yeah.
And they have four papers in theory, the MS exam going students, and the first paper is anatomy, physiology, and optics. So the third nerve and all the cranial nerves, of course, related to the eye, the oculomotor nerve, especially, and the optic nerve. They are like very, very frequently asked questions in their theory. So they have to know in details about the cores and the nuclear complex. Many times they just ask a short note on the third nerve nuclear complex, or how is the central caudal nucleus and Edinger-Westphal nucleus. So they get, and it's a 25 marks question, the theory question. So they have to know everything about, the cause of the nerve and the various problems that are associated with the cranial nerves. So, and in practicals also, the third nerve is like, if a case is there, then it is kept. Sixth nerve is not like very frequently kept, but third nerve case is like very, very frequently kept. So for the exams, so they have to know in details about the all the cranial nerves related to the eye. So I request Dr. Mahesh Sonpetkar and Dr. Rushali to have their comments, because both of them they have mentored their students very well. So Dr.
Yeah.
Mahesh, your comments, please.
Uh, Thank you, ma'am. First, I would like to thank Mos, Dr. Anika madam, Dr. Piyush sir, Vale madam, for giving our students this opportunity to present their cases on the state level. I would also like to thank our state as well as national panelists who have guided them very well and given their inputs regarding their cases. And congratulations to both the presenters. They have presented the case very well. Thank you.
Yeah, and Dr. Rushali, your comments, please. Yeah.
Yes, good evening, ma'am. Thank you all for giving us this opportunity. Mentoring students is a very good way for ourselves also to go back and read and revise, because neuroophthalm is and then the anatomy is so that no matter how many times you read, you need revisions. So it is a good opportunity for us to go back and read. And each time we read, there is a new point that we come across. And it definitely takes you back to a case. Oh, that case, this could have been a differential. Or, acha, this was the thing. So when you keep reading, you see those small things which you may otherwise miss. So it gives you the joy of reading. It also gives you the joy of seeing the patient. And again, it makes you go back to the books. So neuroophthalm is that interesting. So, and there is no harm in for these students to read neuroophthalm. It is just wonderful. It is just how eye and brain work together. So all the students must read neuroophthalmology. It's a very interesting if you take it that way. And thank you, Moss, for giving us this opportunity for us also to go back and read. And both the presenters presented very well. So thank you, everyone. And the inputs from the mentors were from the examiners were really nice. They were very nice and precise questions, which probably must have definitely will make our students go back and read again. So thank you, everyone.
Dr. Piyush, your concluding remarks, please.
I think it was it was elaborated so well by Dr. Rushali that I don't feel like adding anything to it. But many congratulations to both Dr. Pooja, Dr. Snehal. I mean, a lot of revision for me as well. Neuro-ophthalmology is extremely volatile. I try to stick to retina, but it's always nice to go back and revise, and so that we don't miss out anything in our busy clinics. Many congratulations to both Dr. Vishali and Dr. Mahesh for guiding both of y'all so well. And both the external examiners brought so much style and their own fervor to the questions and the answers. So a big thank you from the Maharashtra Ophthalmic Society to both Professor Swati Fulgile and Professor Agashe. Thank you both of you all for sparing your valuable time to be with all of us and giving us these lovely pearls. A big thank you to Numerotech and of course Entod for helping us make sure that these programs are possible. And last and certainly not the least to Professor Archana Vare for stitching everything together. So thank you very much, all of you.
Thank you. Before I leave, I must say, Dr. Piyush Bansal, this is a very good and I think initiation, and students will definitely gain a lot of confidence while presenting, and they will have a lot of learning points also, because every examiner's style of asking question is different, and that gives them a wider perspective about the potential. So that's a very good initiative, I must say. Thank you.
Yeah, absolutely agree. And congratulations to the mentors also, I feel. I mean, they have put in a lot of efforts. We can see that. So very well done.
Thank you, ma'am.
So with this, we conclude this session.